Thank you for joining Cancer Support Community Atlanta for Radiology 101, facilitated by Dr. Sydow with Northside Radiology Associates. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to Radiology 101. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. Cancer Support Community Atlanta continues to offer free support programs virtually to those affected by cancer, which include stress reduction classes, support groups, nutrition seminars, and education programs like these. For a complete list of the virtual programs available, please visit our website, cscatlanta.org, where you can find a complete schedule of events. As a reminder, everyone will remain muted for the duration of the program. We invite you to enter questions into the program chat box, which will be addressed during the Q&A at the end of the program, time permitting. I want to welcome our program moderator, Diane Keene. Diane Keene is the Director of Business Development and Marketing for Northside Radiology Associates in Atlanta, Georgia. She has spent over 20 years in healthcare education and marketing, dedicating the last 18 to radiology practice development. Diane works closely with referring physicians and community partners in developing targeted educational programs for healthcare providers and patients. She has served on the advisory board of Komen Atlanta and is the former vice chair on the board of the Ovarian Cancer Institute. So with that, welcome Diane, and I'll go ahead and pass it off to you to introduce today's presenter.
Thank you, Katie. Thanks everyone for joining us. We are so happy as Radiology Associates, Northside Radiology Associates, to be involved with the cancer support community, and we thank you for being here with us. I want to take a moment to introduce our speaker, Dr. Brian Sydow. We have a lot of radiologists in our group, and they're all wonderful. Dr. Sydow is one of our brightest stars in the cancer community because he works so closely with our oncology providers and patients. So Dr. Sydow was raised in southeastern Pennsylvania. He pursued his medical degree from the University of Pennsylvania after graduating from Duke University. He is smart enough to know he needed to come back down south, which he did, and came down with his wife, settled in Atlanta and at Northside, where he's been with us for the past 13 years. Dr. Sydow is an avid runner. He's an incredible runner, actually. He didn't write that, but he is. And he is also a very avid and loving father of 3 daughters. Dr. Sydow, thank you for being here with us and for giving us your time today and educating us on all things related to imaging and cancer. So welcome, Dr. Sydow.
Thank you, Diane, and thank you, Katie. Thank you for this opportunity to get the word out on cancer imaging and do some education that's so important for patients that go through this process. We'll get started today. So this talk is basically an introduction to imaging as it relates to oncology. We're going to kind of walk through the role of imaging both before diagnosis of cancer, during cancer treatment, and then kind of in the cancer surveillance period. It's going to be an introduction to a bunch of the modalities that are involved in this and the reasoning kind of behind that. To some of the concepts may be very basic to some people, but I hope that there's something that everyone, regardless of where you are in the process of learning about radiology, can take home and apply. So a little bit about me and why am I a cancer imager? What about cancer imaging appeals to me? I entered medicine in general as a service field, and I think in radiology, nowhere is service more evident than in the field of oncology. And what really appealed to me was the longitudinal nature of patient contact, and radiology isn't really a field where you think about longitudinal contact, but with cancer patients, I think it's a little bit different, and that you can see the same patient get scanned, and then you see them get scanned again in 3 months or 6 months, and you kind of get to know them, and the cancer patients kind of become my patients in radiology. And there aren't too many areas in radiology, maybe apart from mammography, where you really get to have that kind of a relationship. And to me, that was very appealing. And I think that oncology, because of the nature of technology and emerging treatments, it's a very exciting field to be in. So I love following the literature and learning about what's going on and applying it to how I read my scans. I think one of the most important things to realize about radiology and oncology is that it is patient-centered. And to all the patients out there, I mean, you really are the kind of driving force behind all of this. And if patients don't understand what's going on and the reasons behind it, then I think we're all missing out, because this really, in the end, is about patients and patient outcomes and having people have the longest and healthiest life they can. So I think I just want everyone to realize that that patient-centered care is at its core. And I personally had an experience with this over the last year. I lost my father last year to lung cancer, and really kind of turned my perspective on looking at imaging kind of on its head. And it was, I just wanted to share what I've learned in kind of going from in front of the camera to, or behind the camera to in front of the camera as my family went through that experience with my father. And it's really definitely given me a new perspective on imaging and oncology and the interplay between the two. So first, just kind of general concepts. Why imaging? Well, the purpose of imaging is to see what's going on inside your body. Obviously, with physical exam, there's just so much that doctors have access to, and really imaging allows another depth of information to be gathered. The tests that we use in radiology use some form of energy to create their image. So in ultrasound, it's sound or acoustic energy. In CT, it's X-ray radiation. In MRI, it's magnetic resonance and radio waves. And with PET imaging, it's positron emission energy. And we'll talk a little bit more about that when we get to that section. But imaging plays a role from diagnosis of cancer through to treating cancers and follow-up of cancers. And I hope that becomes very evident as we go along this presentation. So what is imaging used for? Well, it's used to look for the early stages of cancer. And that would be kind of what we call cancer screening. Mammograms are one example of that. CT colonography is an example, and lung cancer screening CT is another example. We may use imaging to evaluate a symptom like a mass or a lump that a patient feels. Lumps close to the skin surface are often evaluated with ultrasound, whereas deeper lumps in the abdomen, say, would be evaluated more with CT or MRI. And we also use imaging to kind of predict what findings may be. So if a patient feels something, the imaging can hopefully tell us whether that is likely to be cancer, or maybe it's just something benign that we don't have to worry about. It can also help determine whether a biopsy is necessary. And again, tissue diagnosis is generally the gold standard for diagnosing cancer. So even though we may make a suggestion on imaging, the diagnosis is really based more on tissue than any imaging findings. Now, once a cancer has been diagnosed, there's imaging after a cancer diagnosis. That usually involves 4 phases. There's staging the cancer. Staging the cancer means trying to figure out how far the cancer has spread. Usually that's in the form of what we call baseline imaging, which means just basically figuring out where the cancer is from diagnosis. From there, the next stage would be planning, so determining what treatment needs to be done. Is chemotherapy warranted? Is radiation warranted? Maybe it's an embolization. And also, if they're doing radiation, they can use that imaging to kind of focus their radiation beam so that they are only killing the cancer and not killing other normal tissues. So imaging in the planning stages plays a very vital role. After treatment has been initiated, we do imaging for restaging, which determines the kind of response to the treatment, determine if the cancer has shrunk, has it stayed the same, has it grown, do we need to change therapy? So imaging is important there. It also can help to detect recurrence. So assuming that the cancer was treated and is gone, how do we know if the cancer's come back? So we use imaging in that regard to determine if the cancer has come back. So does imaging tell the whole story? Well, the obvious answer is no. So lots of things can factor into interpreting the images and determining the meaning of those images. And those include medical history, physical exam, blood work, pathology work, and also realize that not every patient is the same. So you can have the same cancer in two different individuals, but it may act completely differently depending on what else is going on with that patient, their comorbidities, and that's very important. And not every cancer is the same. So obviously a lung cancer is going to behave very differently than a thyroid cancer or an ovarian cancer. So it's important to take that into account. And also to remember that the goal of every oncology team is to ensure the best outcome, and that it takes a village. And we do this in the forms of tumor boards, where all specialists from different areas get together and discuss patients, discuss the imaging, determine a plan. So that's the tumor boards, I think, and I had a tumor board this morning for liver and pancreas, but it's a great example of how it really is a team approach, and that imaging is really complementary to the roles of everybody on the team. And again, the people on that team may be the medical oncologist, they may be the geneticist, people from lots of the surgeons, surgical oncology, radiation oncology, and everybody has input into those individual cases. So there are limitations of imaging as well. For one, in order for an imaging test to show a cancer, it needs to have a large group of cancer cells on the imaging study. No imaging test can show a single cancer cell or even a few cancer cells. And this is why treatment may continue even after the cancer cells can't be seen on imaging. So you want to try and kill off even the most microscopic foci of cancer that you can't see on the imaging. And again, it takes millions of cancer cells to show up. Also, imaging can sometimes show something that looks like a cancer but isn't. And again, highlighting the importance of getting a biopsy, and also, as we'll talk about later, not just looking at the anatomy of the imaging, but also functional imaging like PET. So who performs and reads imaging? Tests are generally available as outpatients and inpatients. The images themselves are performed by certified technologists that actually run the CT scanners or run the MRI scanners that do the ultrasounds. The images are interpreted by physicians who are experts in interpreting scans. In general, that's going to be radiologists. So as a radiologist myself, my job is to interpret the images. I prepare a report with the findings from those images, and then I send that report to the ordering doctor. A copy of that report becomes part of the medical record for that patient, and your doctors may look at those images as well. And referring doctors or patients may contact the radiologist if there's a question about the report or in comparison to something they had done before. Now we're going to turn to the imaging modalities themselves and give you an introduction into the different technologies that are available. So we'll touch on mammography, not really X-ray so much, ultrasound, CT, MRI, and PETCT. Okay. And it's always tough, especially for people that don't have a background in imaging, to really put in terms of what the differences are between the modalities. So I put together this slide that just kind of summarizes the roles of the different modalities and kind of the pluses and minuses of each. I'll just kind of summarize. MRI is really a workhorse for diagnosis and screening, especially as it relates to breast MRI for screening. The cost, however, for MRI and PET, as you can see, is very high. MRI and ultrasound have advantages in that there's no radiation. MRI is very noisy and is very time consuming. So those are on the negative there. Ultrasound obviously has no noise. And And then in terms of biopsy treatment and planning, you'll see that ultrasound oftentimes is used to guide biopsy, and CTs and MRIs are more used, and PET more used for treatment planning like we talked about. And the use of contrast is usually most necessary with CT and MRI. And you can see that ultrasound is mainly for superficial findings, whereas CT and PET are more for deep findings, and MRI as well. So the modality and how effective it is also depends on the cancer that we're looking at. So this, again, is another summary table that just kind of shows which cancers there on the left-hand side utilize which imaging modality the most. Obviously, you can see a lot of the workhorse imaging is being done by CT, MRI, and PET. You'll notice that breast cancer is a little different in how that's worked up between mammography and ultrasound, and MRI with CT playing a lesser role. And you'll also notice, like in the brain or the spine, neuro type malignancies, you know, where MRI is going to be the workhorse there. And thyroid as well at the bottom. Ultrasound is going to be more of a workhorse in that, in thyroid cancers. So just keep that in mind as we walk through this. We'll hit on some of these points as we go through these different modalities. Just to show you what the images look like, some of you may have seen some images from CT, ultrasound, and MRI before, but just to show you, this is what we see. The image all the way on the left there is an ultrasound image that shows this echogenic mass in the liver. You can see the same mass, what it looks like on the CT there. You can notice on the ultrasound that the field of view is somewhat limited to just the liver, whereas on the CT scan, you can see all of the internal organs as well as the spine and all the ribs. On the right-hand side, you'll see a contrast-enhanced CT, and then next to that is a PET-CT that shows uptake in a mass. That's in yellow there. The other yellow structure there on the PET-CT is the spine, which takes up the radio tracer that we inject for PET-CT. You can see the same patient had an MRI there. And this is a contrast-enhanced MRI showing you that mass in the retroperitoneum. And then when they fuse the PET images to the MRI, you can see what the PET MRI fusion looks like there as well. So CT, this is what a CT scan looks like. A lot of the imaging modalities kind of look similar. They're all kind of round, you know, donuts where patients lie on the table that you can see there and kind of slide in and out of the scanner. We try to do everything we can to make the patients as at home as possible. You can see that this scanner room has a nice wood floor to it. It has a mural there on the wall of a waterfall. There's another light on the ceiling there that shows clouds. And this is indicative of what a lot of imaging rooms are looking like these days, to try and put the patients at peace, reduce the anxiety of the study. And so we'll just kind of walk through what a CT scan entails. The advantages of CT is that really CT can be performed of any body type, any body part. It's very reproducible, very comparable, very accurate. So if a patient's getting scans every 3 months and they want to know, is the cancer bigger or smaller, CT is a very good way to do that because the technology is very reproducible. It's relatively inexpensive, it's relatively quick, and it is painless. The disadvantages of CT are obviously radiation exposure, and it is relatively invasive in that patients probably will need contrast for most CT examinations when we're doing it for oncology. A CT scan usually takes about 10 to 20 minutes, and the role, again, is pretty wide here. It can everything from diagnosis to staging, guiding biopsy, guiding treatments. Lots of uses for CT. It's really kind of the Swiss Army knife of oncology workups. The technology uses standard X-rays. These X-rays form a broad beam that pass through the patient, and there's a computer that reconstructs the X-rays to determine what tissues they are based on how much that tissue blocks the X-ray beam. Contrast, intravenous contrast, is often given to better separate the soft tissues in the area being imaged. because without the contrast, a lot of the soft tissues will attenuate that X-ray beam to about the same extent. So you really need the contrast to kind of differentiate what's a spleen from a liver, from a mass inside the liver, things like that. It just increases the conspicuity of the findings that you'll see within that organ. If patients have an allergy to IV contrast in the past, they should talk to their doctor or talk to the radiologist before getting IV contrast again. Allergic patients often require a steroid prep before they're re-imaged. Oral contrast can be given in addition to intravenous contrast material. Oftentimes, especially in older patients, we will check a patient's renal function because sometimes the IV contrast can affect the kidneys, and so we kind of want to know what the baseline renal function is when we do a CT scan. So we'll kind of screen patients for any risk factors that they may have for kidney disease, including their age, and check kidney function on some of those patients. In terms of preparation, sometimes CT can require special preparation, like not eating or drinking after midnight. Sometimes, like with CT colonography, you may need to use a laxative or an enema. But generally, the preparations are pretty minimal. We do use CT for screening, and the two examples are CT colonography, which is like screening for colon cancer. And in that modality, the computer recreates the three-dimensional anatomy of the colon. It has the same prep as optical colonoscopy, which is the downside. But it is, a non-invasive technique, and it does have equivalent cancer detection to optical colonoscopy. Lung cancer screening is another example of a newer modality for using CT for screening purposes. You can see on the left is the criteria that are used for determining who would be an appropriate candidate for lung cancer screening. Generally, it's 55 to 75, current or recently quit smoking history, and a fairly significant smoking history, at least 30 pack years. And for lung cancer screening, what we usually recommend is annual screening CT for that condition. So what is CT like? So before the scan, you may be asked by the technologist to undress or put on a gown. You may be asked to remove your bra or jewelry, piercings, or other metal objects. On CT, metal objects can introduce artifacts. So obviously, when we image patients with CT, we want to minimize the number of artifacts that we can see. And also let the technologist know if you have any implanted medical devices that are under the skin surface. This won't preclude you from getting a scan, but we may take extra care in those areas. During the CT scan, so as I already mentioned, the CT scanner is basically shaped like a large donut. Patient lies on the flat table, and the table moves in and out of the scanner. The CT tube, the X-ray source itself, is encased in that plastic housing around the tube, and it spins around the table within the housing while the patient is inside. So because it spins around the patient, you may hear a buzzing sound that's kind of a whirring sound of that tube as it spins around in the housing. These scanners are very well balanced, so there really shouldn't be any knocking or other loud noises, but you probably will hear a buzzing sound. You will be alone in the room when you have a scan done, but the technologist will be able to see you, hear you, and talk to you. There is a window, usually in the CT scan rooms, where the technologist looks in from the control area and can physically see the patients. And the scanners usually are oriented in such a way so that even without a camera, the technologist can see the patient's head or body for the most part. For CT, you do need to lie still. Being still is very important. Again, any kind of motion on the scan does introduce artifacts. When you're getting your CT scan, you always want to pay attention to any audio messages that are played by the technologist. They may say to stop breathing or take a breath in and hold it. And it's really important, again, to follow those commands to avoid any artifacts during the scanning. When the contrast is injected, you may feel a warm feeling all over your body. Some patients describe the sensation of wetting their pants or a metallic taste in their mouth. If you experience any sensations that make you uncomfortable, please let the technologist know. Contrast doesn't act the same in all patients, so you may think, oh, that's just me having that reaction or that experience, but it may be something that we see in other people, so definitely let the technologist know. Allergic reactions can occur to contrast. In general, they tend to occur immediately after the contrast is given. Usually they're mild, but they can be severe. So again, it's definitely important to let the technologist know if you feel anything unusual. And a typical allergic reaction that would be mild would include usually itching or hives, but could include difficulty breathing or tightness in your chest or throat. So again, important to stay in communication. After the scan, patients are monitored for approximately 10 to 20 minutes to assess for any adverse events related to the contrast. And the IV is usually left in place until the patient leaves the department. So that'll be like the last thing. It's usually like when patients get CAT scans done, it's usually the first thing they want done is like, can we take this IV out? But in general, it's usually the last thing that we do, just in case we need to give any medication before the patient leaves. So if anybody really, next time you get a CT scan, if you really want that IV out right after the scan, I understand where you're coming from. So we'll move on to MRI. This is an example of an MRI. And you can see in comparison to the CT scan, the MRI scanner is a little bit bigger and a little bit longer. So the board diameter, which is the size of the circle in the middle, it can be about the same size as a CT scanner, or it may be a little bit smaller. In general, the thickness of the scanner, though, MRI is going to be a thicker cylinder, a thicker donut than a CT scan. So just keep that in mind as we talk about some of the advantages and disadvantages. So the advantage of MRI, obviously there's no radiation with MRI. It uses magnetic resonance. In terms of oncology, the big advantage is soft tissue characterization. So it's very good for solid organs, very good for joints, very good for central nervous system. It can be done on any body part. It's less dependent on contrast because there's more inherent soft tissue resolution, soft tissue contrast with MRI without the contrast. So you can tell what a liver looks like compared to a spleen, compared to kidneys, even without the contrast. And we can also manipulate the magnetic field with an MRI to make lesions in a liver, say, look more or less conspicuous. So we can do that all without CT, without contrast. And MRI is very accurate in that if you see a mass, it can usually very readily be characterized on the MRI. And MRI is also painless. The disadvantages is obviously MRI is quite expensive and it's quite time consuming, and we'll go over that. Sometimes MRI examinations can take up to an hour, even over an hour for some MRIs. And so it's usually more of a focused examination. If you're looking at the liver or the abdomen, it's a little less optimal if you're trying to do like a whole body screening examination. Unless you really kind of limit, what you're doing for each body station. So it can be, it can be time consuming if you want to do large fields of view. In general, though, MRI is, again, less tolerable than CT for those reasons that we talked about. Number one is claustrophobia. It's again, a tighter space. And the other is the noise, which we'll touch on. MRI is a very noisy thing. So as these magnetic resonance gradients switch on and off, that usually makes a very loud knocking sound. And I encourage patients, if you haven't had an MRI, there's videos, audios on YouTube that you can listen to of what an MRI scanner really sounds like. And it's, I remember when I first, sat in on my first MRI examination, and it was a lot louder than I thought it was going to be. So just something to pay attention to. MRI sometimes can be less reproducible and more variable. That's just from differences in technology. Different scanners produce kind of different looking images a little bit, different vendors. If you have an MRI done on a GE scanner versus a Siemens scanner versus a Hitachi, they may look a little bit different from one another, whereas CT is more uniform. If you get a CT on a GE scanner, it looks very similar to a Siemens scanner and whatnot. But MRI is generally a little more variable in that regard. We talked about the time already. The time is variable depending on what you're looking at and how big of an area that you're looking at. Role, MRI is very similar to CT in that it can be used basically at all stages of cancer, from diagnosis to detecting recurrence. It's less used with biopsy guidance. In the areas where it is used most would be breast MRI and prostate MRI. Those are two indications where MR guided biopsy is being used more. It is very good, however, in guiding treatment and determining what fields. So, for instance, if you have a cancer that has a very cellular center to it, but the rim is very fibrotic, obviously, if they're going to radiate that, they want to make sure they include the cellular area, and they can probably use less radiation in the parts of the lesion that may be fibrotic or scarred. So it can help determine what's of use. And also for like image-guided ablation, the MRIs can be very good at guiding ablation of, say, masses in the liver that are going to be metabolically active, whereas ignoring masses that may be treated. So it can be very important in that regard too. So talking a little bit more about what is behind MRI, the technology. Again, it's a long cylinder, very large and strong magnet. We talked about the claustrophobia. Unlike CT, MRI has no spinning parts. So we talked about in CT how that tube spins around the patient to make the image. With MRI, it doesn't move, but it switches these magnetic gradients off and on. So it emits a burst of radio frequency waves to pick up signals from hydrogen ions in the body. And that's kind of important, is that like MRI is tuned to image hydrogen atoms. Technically, you could use MRI tuned to other molecules or other ions in the body, but because hydrogen is in everything, we choose hydrogen because it's so abundant. And therefore, imaging times can be less because it is so abundant. MRI uses an antenna to pick up the signal, which has spatially encoded information from these hydrogen atoms and turns that into an image. And we won't go more into detail. That's like a whole lecture in and of itself in terms of how an MRI image is created. But just to say that the stronger the signal, the stronger that antenna and that signal going to the antenna, the better the image. And we can make that signal stronger by repetitions or repeating the number of acquisitions from a particular body part. We can increase that signal by increasing the strength of the magnet. And that's why you may have heard that like 3 Tesla is better than 1.5 Tesla. It's because that magnet's stronger. And that signal that those hydrogen ions emit is bigger. And also the distance that the signal has to travel. So obviously when energy goes through a medium, it can decay. So the closer you can get that antenna, kind of like getting a radio signal in your car, the closer you are to the source of that radio station, the clearer the signal is going to be. And in MRI, it's the same thing. When you have that antenna positioned along a patient's surface that's very close to the area being imaged, the signal is going to be clearer. And we'll talk about setting up an MRI in a second. So contrast, brain and spine, the best way to see masses is with contrast in those situations. Sometimes, again, we can differentiate cancers from other soft tissue masses without contrast. And gadolinium is the contrast agent that we use for MRI. Standard route of administration is intravenous. And you can let your technologist know, again, if you have an allergy to gadolinium or CT contrast. Breast MRI can be used for screening. Traditionally, it's in patients that have gene mutations, BRCA being the main one. Dense breast tissue, there's increasing interest in doing abbreviated MRI protocols for breast cancer screening as a supplement to mammography. So that's something to keep an eye out for, especially as the breast density legislation becomes more the national standard. Preparation, claustrophobia. Sometimes patients can take medications to help them relax before the MRI. As radiologists, we kind of usually leave that up to the referring doctors to determine what the appropriate medication is. If a doctor called and asked me, I could make some recommendations, but I feel best letting the referring doctor make the determination about which medication to use because they know the patient the best and what medication the patient may or may not have a reaction or bad experience with. As you're preparing, especially for your first MRI, I think it's good to talk to technologists before the MRI and actually see the scanner. That can usually kind of decrease your anxiety about what it's going to be. And just know, again, that there are both closed bore and open bore MRIs. So a wide bore MRI is about the same diameter. That's the diameter of that central opening is about the same diameter as a CT. There are closed bore MRIs which are a little bit smaller than a CT. More of the newer scanners are going more towards wide bore geometry. And again, the bore itself, the length of that donut can be variable. So there are long bore scanners and there are relatively short bore scanners. And again, more of the technology, well, I shouldn't say that. More of the technology these days is kind of a balance between long and short, because if it's too short, then you're really kind of restricting your field of view that you can image. So we do want some length on the MRI. So getting a real short bore MRI is not necessarily, the best imaging study. But having the short bore and having a wide bore MRI can really help people that are claustrophobic. So, and in terms of preparation and contrast, gadolinium contrast in general has more of a reputation for making patients nauseous than CT contrast. So I always advise that it's usually a good idea to forego eating for about 3 or 4 hours before the MRI, just so that nausea doesn't tend to kick in as much. So what is MRI like? There's a pretty extensive screening process that patients go through before they go to the MRI area. And you can notify the technologist if you have any of those metal items there. Other metal items that would be important would be listed below: staples, screws, plates, things like that. You'll get an extensive history about operating around metal. If you've ever been a welder or worked with metal, we may ask you to get an x-ray of your orbits before going in, just to make sure that you don't have any occult metal foreign bodies in your eyes. And you may be asked to remove metal objects before going in. When you get your MRI done, you will lie flat, similar to the CT scan. You will be alone, like the CT scan. Usually they give patients a squeeze ball, so you can squeeze it if you need assistance, because again, the scanner is usually a little bit more of a closed system, so the technologist may not have as much direct access to your facial expressions in your face. Some of the scanners these days actually have cameras built into the bore of the scanner, so like this or FaceTime, the tech can actually see your face during the entire scan. But just in case they can't, they will give you a squeeze ball. Ear protection is important. Again, it says very loud, so most of the time you'll be given at least earplugs, if not like headphones that can play music and things like that. So that will be done. And you will be given instructions, similar to CT scan, to hold your breath or things like that. The techs will usually give you progress reminders. I think our MRI techs are part cheerleaders, because these scans can be long, and so they'll kind of encourage you to keep going. Hey, we've only got 3 scans left. You've only got 2 minutes left. In general, each sequence within an MRI takes about 3 to 5 minutes, and usually about 5 to 10 sequences are required per exam. So that'll give you an idea there of the of the time involved, like we mentioned before. You may get an opportunity to rest between these sequences for MRI, so you may not go straight through. If you do need a break, you can let the technologist know, and usually they can give you a minute or two to catch your breath or just recoup your spirits before going on. They do use a coil, and this is where that antenna comes into place. This coil contains the antenna that receives the data from those hydrogen ions. So they will put a coil over the area being imaged, and it may be a knee coil if you're getting your knee done. It may be a head coil if you're getting your brain imaged, but they do usually put some kind of coil over the area being imaged. And the placement of that coil is really important because it really determines what kind of imaging quality you're going to get in that area. There are quote-unquote open MRI systems. In general, these are not ideal for most oncology applications because we want really high detail images, and a lot of times those open MRI scanners just aren't able to give us the kind of detail that we need to make these important treatment decisions. And quality control. Sometimes at the end of the MRI, the images will be checked by the radiologist and to make sure that nothing needs to be repeated. Again, no metal, no magnets in the scanners. Credit cards can be deleted. Panic attacks can occur, so if you're experiencing anxiety during the scan, please let the technologist know. We talked about the nausea. Gadolinium can be associated with fibrosis of the skin. Very uncommon these days, but I wanted to mention it because you may have heard about it through talking to friends or in the literature. And gadolinium deposition is a hot topic these days. Gadolinium deposition does occur in all organs, most noted and studied in the brain. The effects at this time are unknown, but it's felt likely to be insignificant. All the studies thus far have shown no associations with any specific condition. But we do try and choose a gadolinium agent that's going to choose the least amount of deposition, even though we don't exactly know what the deposition could lead to. We try to choose agents that are that deposit the least. And we are required by the FDA now to give patients information on gadolinium deposition. So if you get an MRI, you'll probably be given a pamphlet about this issue. Gadolinium may not be given if you have impaired renal function. So we usually check renal function on some patients prior to MRI. Obesity can be a factor, obviously, if you can't fit inside the bore diameter as well. So that can be an issue sometimes as well. MRI is generally avoided in the first trimester of pregnancy, but we will do it if medically necessary. We very rarely give gadolinium contrast during pregnancy. It's contraindicated. And patients, again, are generally monitored for 10 to 20 minutes after the examination, and the IV is removed at the end of the waiting period. Ultrasound, this is an example of an ultrasound machine. We're going to go a little quicker through some of these modalities. Ultrasound has the advantage of that it's a real-time examination. There's no radiation. It's very functional, can be used to guide biopsy. It's low cost, painless. There's no noise. But the disadvantage is it's operator dependent. So depending on who the ultrasound tech is, the images may be less reproducible. So in general, it's not used for staging so much and things like that where you want real reproducible images. It's better for superficial findings because the ultrasound begins on the skin surface and is directed in. Ultrasound can't penetrate air or bones. In general, the exams are a little bit longer than CT, but not quite as long as MRI, about 20 to 30 minutes. And it's better when you need to evaluate like a specific organ or like guide biopsy. The technology, again, ultrasound is a high-frequency sound wave. The sound basically bounces off the organs, and that information is used to create an image. Contrast, generally not used in the U.S., although it is used more widely in other countries. Ultrasound does play a role in screening, but not as big of a role, I would say, compared to CT or MRI. There is literature about screening breasts for breast cancer as an adjunct to mammography using ultrasound. And also it can be used in the liver for screening for hepatocellular carcinomas in patients that are at higher risk for that condition, although in general MRI is more preferred these days. Not really any preparation per se. Some scans may require you to have a full bladder, like a pelvic ultrasound. You may be asked to undress and put on a gown. During the scan, it's usually just the patient and the technologist in the room. Some ultrasound examinations, like a transvaginal ultrasound, may require a chaperone, so they may ask for another person to come in the room with them while they do certain parts of the scan. Patients, again, usually lie flat on a stretcher. They use gel on the skin surface that acts as an interface for the ultrasound transducer. And then the ultrasound guides the handheld transducer along the surface of the body part to be imaged. There can be kind of internal ultrasound probes, like I mentioned, the transvaginal ultrasound. They also do ultrasound like through endoscopy, where they put the scope down into your esophagus and look across the esophageal wall. That's another type of ultrasound that's done. So ultrasound probes can have different appearances. After the exam, the gel is generally wiped away, and again, the technologist may get the images checked, and sometimes the radiologist may come in and actually scan themselves. In general, that's not something to be alarmed about if you're a patient, but just to realize that from time to time you may actually see the radiologist imaging. PET-CT. So PET-CT scanner looks very similar to a CT scanner, as you can see it there. It just has two different cameras that are mounted in that plastic housing. PET-CT provides anatomic and also functional information, less dependent on contrast. There is high anatomic detail. It allows whole body imaging, which is different from some of the other techniques. So you can get basically a PET-CT scan done from head to toe if you wanted to stage something like, say, a melanoma, which is more typically where we use whole body PET-CT. The disadvantages of PET-CT are that it's expensive. And actually, one thing I forgot to mention is that another advantage of the PET-CT is that it can differentiate scar tissue from tumors. So if you look on the image there on the left, under A, you can see this cancer that takes up the radiotracer in the left lung. And then in the row D there on the bottom is after treatment. You can see that the cancer has shrunk and takes up less of the radiotracer. And then you can see on the right in C and F how they use that imaging to guide the radiation field, which is colored there in green, just to show you how the images are used to map some of those treatment plans. So disadvantages, again, expensive. It depends on the tumor biology. If a tumor is not rapidly dividing, it won't necessarily take up the radiotracer. Availability in general, PET-CTs are less available than CT scanners. And there is considerable radiation, more radiation for PET-CT than CT alone. It's time consuming. PET-CTs can take up to 90 minutes, because generally you have to wait an hour after you're injected with the radiotracer before scanning begins. Again, it's PET-CT is a workhorse. We do it for a lot of different reasons. The technology, again, generally FDG PET, which is the one we'll talk about, uses a radioactive sugar. The body takes up different amounts of that sugar depending on how fast the cells in the body are growing. Cells that grow more quickly will take up the sugar to a greater degree. The scanner uses what we call coincidence detection in order to determine where that activity originated in the body. And that, again, is another lecture unto itself to explain how a PET scanner forms an image. But it's basically from this particle that's emitted in opposite directions by that sugar molecule. And the PET images are overlaid on the CT that are acquired at the same time, which is why it's all housed in the same plastic housing. Contrast may be combined with a diagnostic CT, but it's not required. Again, the injection of the radiotracer, depending on what they're looking for, that period may vary. But again, for FDG PET, which is the most common, it's generally waiting an hour. Preparation, no strenuous exercise or deep muscle massage 48 hours before the scan, because you don't want your muscles to take up all the radiotracer. You want your cancer cells to take up the radiotracer. And no eating or drinking for 6 hours before the scan, only water. And if you're diabetic, you want to talk to your doctor because they might not want you taking insulin the morning before. Again, the insulin may drive that radiotracer into your muscles and not the cancer. Before the scans, your blood glucose is checked. They want it to be less than 150 to 200. After they do the injection, you'll be asked to kind of just rest. They don't want you doing anything really physically active for that hour. And then during the scan, you lie flat on the table. You'll be given some breath hold instructions. No breath hold instruction for the PET, just the CT. And then no instructions after the scan. Moving on to mammography. Advantages of mammography: it's low cost, well studied, no contrast, it's quick, low radiation dose, especially compared to CTs and PETs, and it can detect cancers before they're felt. So this is like the true screening study. Disadvantages is that obviously if you've ever had a mammogram done, which I haven't, but it's very painful, obviously, to get the scan done, and not all cancers are seen on mammography, and some patients may need supplemental screening, especially as we mentioned, the BRCA or dense-breasted women. It's a relatively quick study, 15 to 30 minutes, and again, it's used for screening. It also can be used to work up focal breast problems like a lump, which is usually used in conjunction with an ultrasound. Technology, it's a low-energy X-ray beam that passes through the breast and is captured by a detector. These days, we're using 2D and 3D, a thing called tomosynthesis is the 3D image. One or both may be acquired in a patient. In general, three-dimensional, the tomosynthesis is used in denser breasted women. The 3D images are also thought to decrease the callback rate for mammography. There's no contrast again. Preparation, no deodorant. And consider, administering anti-inflammatory pain medication prophylactically because the mammogram can be uncomfortable. And on the left, you can see the BioRad scoring system that we use for reporting out mammography. Patients will receive a copy, different than some other radiology reports where with mammography, patients do receive a copy of the recommendations. That's national legislation. And again, breast cancer lifetime risk starts to become important these days because lifetime risks above 20% are considered for additional screening besides just mammography. And we'll touch on that in this next slide, which talks about breast density. So on the left, you can see a mammogram that shows kind of the spectrum of breast density from fatty tissue to extremely dense tissue. Again, breast density is a required element of the mammography report in Georgia. You can use these risk calculators. Again, lifetime risk is a bigger issue these days. So if you want to know what your lifetime risk of breast cancer is, you can actually go to these websites and do your own calculation. You can see a genetic counselor and they can help you do a calculation. It'll give you some sense of where you stand. The average woman has a risk of about 1 in 8 lifetime risk of breast cancer, but that risk can vary depending on breast density, depending on family history, depending on what your breast history is, if you've had any other biopsies and what they've showed. So all these things can help you figure out what your specific breast cancer risk is. So I encourage people to look into those calculators or talk to a genetic counselor. Recommendations, again, for supplemental screening, which you could look at a later time. I won't go into it in depth, but just know that there are additional recommendations to be considered if you are in one of these higher risk groups. Breast MRIs is the last thing that we'll talk about. And breast MRI is important for oncology patients because it does play such a large role of staging breast cancer patients these days. It's a detailed look at the breast, but not just the breast, but also the regional lymph node anatomy. It's excellent at soft tissue resolution. The disadvantage is that it's expensive, it's time consuming, it's uncomfortable because patients have to lie on their stomach. It may detect non-cancerous masses that need biopsy, and that can lead to, emotional disturbance and things like that over lesions that aren't cancerous, but you're made to go through a biopsy to prove it, and the emotional toll and stress that can take on a patient. It is time consuming. Breast MRIs can take 45 to 60 minutes. The gadolinium contrast is required for breast cancer MRI. And the use, it helps to determine the extent of a breast cancer. So if you've already had a cancer diagnosed, they can use the MRI to determine the extent, accurately size the cancer, because the size of the lesion determines what the treatment may be. It can look for other cancers. So some women may have 2 breast cancers at the same time. They may have cancers in different breasts. So a lot of times they'll want to get an MRI to look at that. And obviously your family history, your genetic background is important in making that determination as well. But again, not every woman that's diagnosed with breast cancer may need an MRI. So that's important as well. Breast MRI may be used to screen patients, again, for those high-risk groups as a supplement to traditional mammography. In general, they'll alternate. They'll do a mammogram, and then 6 months later do an MRI. 6 months after that, do a mammogram. 6 months after that, do an MRI. So they usually alternate 6 months in those higher-risk patients. Just a note about interventional radiology. This is a subsection of radiology that has a large impact on cancer patients, everything from vascular access for chemotherapy, so putting in like your chest ports or central lines for chemotherapy, to treating cancer with radioactive embolization of liver masses. Maybe it's a CT-guided radiofrequency ablation of a liver mass. They'll put in stents. If a cancer blocks up your kidneys, they can open that up with stents and things like that. And that's something that interventional radiologists do. They also can perform biopsies. So biopsy could be performed anywhere along the stages of a cancer, from diagnosis to staging to recurrence. So we do image-guided biopsies at all those stages of imaging. So that basically wraps it up. I wanted to come back to the imaging dashboard that we touched on in the beginning. And just realize that different imaging modalities have different strengths, different weaknesses, different uses, and I want patients to be educated on that. It's important. And empowerment. I hope at the end of this talk that the people watching it feel empowered about imaging as it relates to their diagnosis of cancer, or any use of imaging in any diagnosis that you have going on. Knowledge is king. Prepare for your exam, know why the study is being done, know the expectations for the results, what is this going to show, how is it going to help my doctor, and ask questions. You can call the radiology department and ask questions, you can talk to your referring doctors and ask questions. During the examination, it's really important to follow the instructions that are given to you, and I hope I explained to you why it's important to follow those instructions. And communicate your questions and concerns during the examination to the staff, to the technologist, to the radiologist. And after your exam, we want to make sure that you're satisfied with the results, because again, the end result, the end goal of any imaging study is patient outcome. So if we're not having a good patient outcome for any reason, we should all be aware of that and make changes to make that better. And so talk to your physician, talk to your radiologist. And some hospitals offer imaging reports in lay terms. You may hear about that. I just want to bring it up because you may hear about it in literature or something like that. In general, I'm more in favor, there may still be terms in those reports that you don't understand. I'm more inclined to have you reach out, have a face-to-face conversation about studies rather than just relying on written reports so much. So I would encourage patients, if you do have a specific question, to reach out and get those questions answered, than just relying on a report. And thank you. You can follow me on Twitter if you want. I usually will talk about a lot of things related to oncology. The latest topics for me of interest have been opportunistic imaging, how body composition relates to cancer prognosis, and imaging biomarkers, and identifying imaging findings that enhance outcomes. So if you want to hear about those topics, you can follow me on there. And thank you very much for your attention, everyone.
Thank you, Dr. Sydow. Gosh, great information for all of us, those of us listening who are work in the medical field, and those of you who have cancer or have had cancer or have loved ones who have cancer, I think all of this has been extremely helpful. We've gotten some really good questions in that I'm going to pose to Dr. Sydow, but before I start asking him the questions, I did want to touch on just a couple of points that Dr. Sydow made. One point that he made was he's never had a mammogram, so he can't quite speak to the comfort of a mammo. And ladies who have had this before, and some gentlemen as well, while you know that it isn't especially comfortable, one of the things for those of you in the Northside family, in the Northside area in Atlanta, we do have new technology that includes a curved paddle. So the actual part of the machine that's pressing down on your breast now has a little bit of a curve. I had one just a couple of weeks ago, and it is incredibly more comfortable. So good news for the ladies having their annual screening or their follow-ups or their diagnostic or whatever you may need. It is a little more comfortable than it used to be. So that's good news. The technology is also improving, and we have high definition 3D available as well. Another thing I wanted to touch on, we have a lot of questions coming in about mammo and about breast cancer. And while Dr. Sydow will answer some of those questions and has done a great job, we will be having another session. The date isn't determined, but we will know soon, specific to mammo and specific to breast cancer. So some of those more in-depth questions that you have related to mammography and breast cancer, we will be doing a session specific to that as well. We will also do one on interventional radiology, so we can speak more specifically on some of the treatments available for patients with cancer and metastatic cancer. So look forward to those in the future. Another thing too, before Dr. Sydow starts, one of the questions that we've gotten multiple times is the use of ultrasound for patients with dense breast for screening. And as Dr. Sydow mentioned, we don't typically use ultrasound for screening, but for those patients with dense breast who are interested in additional screening, Northside does offer something called a fast breast MRI. Dr. Sydow mentioned that. It is something that is available for those patients who aren't necessarily high risk for any other reason, but they have dense breast. So we're happy to answer questions for you in the mammo session that we do later specific to breast fast MRI, or you can ask your provider about it. So now, Dr. Sydow, I'm going to ask you some of the questions that we have coming in. One of the ones that just came in is a patient wants to know, is there anything they can drink or any amount of water that's recommended to help flush the contrast out of their system quicker?
Yeah, that's a good question. There's not a specific amount, but you know, in general, being more hydrated will help get that contrast out better. In general, patients that don't have any underlying renal issues should be, you know, have negligible risk at having problems with the contrast blocking up their kidneys. So not a general amount, but my recommendation is just the more the better, you know.
Okay, great. Thank you. Another question that a patient had, this is regarding a PET scan and lab work. There's a they want to know if they've had blood work done that shows that their tumor tracing numbers, this is how the question was posed to us, is high, but the PET scan is negative. What comes next? I know you mentioned that no modality and no test is absolutely ideal, and that's why we do a lot of these in conjunction with another. So what might a patient ask or do next if this happens?
That's a good question, and it's really a tough situation for, you know, for an imager, because, you know, as I touched on in the talk, not all cancers are the same. And even within cancers, you know, that a cancer in one person might not behave exactly like a cancer in another. So you may have a situation where you do have a cancer that makes a certain marker, but it's just not metabolically active enough to be evident on a PET-CT. So that's where other imaging modalities like MRI may come into play, like CT, you know, occasionally like a laparoscopy even to take a look if an imaging modality is negative. And then the other thing too is, you know, making sure that that tracer is specific to cancer, because you do have some tracers that can be made by potentially other non-cancerous, there could be non-cancerous causes for some of these markers to be elevated. So, it may cause them to look into, other potentially etiologies for that elevation.
Which is another, perfect example of why it is so important that our radiologists and our oncologists and surgeons and pathologists all work very closely together to give you guys the best outcome possible. Yeah. Another question, let's see here. For patients who need an MRI, but they fear that they may have issues with claustrophobia or panic attacks. I know in the past we've had patients who don't ask in advance, and when they get to the scan, it might be a little too late to get that arranged. Is that something they should speak to their referring physician about prior to coming in?
Yeah, I would encourage you to talk to your referring physician prior to coming in, and again, I think talking to the MRI technologist ahead of time can be helpful as well in that regard. We can schedule patients with sedation, but those are usually patients with very severe issues. The mild anxiety, we generally let the referring doctors handle.
And we typically would ask that a patient have a driver if they've been pre-medicated for anxiety.
Absolutely.
We don't want you taking something that will make you relax too much to drive home.
Correct.
So another question, let's see, we just got one more in. What would be the difference, and you touched on this a bit, but maybe you can expand just a moment on whether or not the doctor at any specific time would order simply a PET or a PET combined with CT? When do you need which?
Yeah, it's a good question. And it really kind of depends, I think, on what's the role of that PET-CT and what tumor we're looking at. If it's a tumor that is, if the patient has had, say, PET-CTs in the past and the tumor is very avid, it's very obvious where the cancer is, then the contrast probably isn't as important, because we know if there's even a small area of disease, we'll see it on the PET images. But if there's a cancer, say, that doesn't take up the FDG as avidly, or you have some lesions that do take it up very avidly and some lesions that don't, and you want to make sure that you're staging every aspect of the patient's cancer, that's a situation where you may want to do a PET-CT with the PET contrast as well as the CT contrast. But it really depends on patient-to-patient situation and like a scenario-to-scenario situation. There's not like one set golden rule or standard as far as I'm concerned.
Right, thank you. So another question, and forgive me as I look down, I'm reading the questions that have come in. So a couple questions about interventional radiology. And again, I will remind you guys that we will be doing a session very specific to interventional, where we can get in detail about the procedures that we do and what sort of cancers that those procedures and treatments are done for. One of the questions, though, was, can you talk about IR and how it can be used for someone whose cancer has metastasized? And again, I think Dr. Sydow touched on that a bit. We will certainly be approaching that subject more on the IR talk, but we see this quite a bit. We see IR patients that have had breast cancer that have metastasized. We treat a lot of liver cancer, and it doesn't necessarily mean the cancer started in the liver. So for those patients who have had cancer that has metastasized, sometimes it does affect the liver, and a lot of the advanced procedures that our IR specialists do are related to liver as well. So if you want to add to that anything, or?
I think you pretty much covered it.
Okay.
Yeah, I mean, it's these days, again, with the functional nature of imaging, the interventional stuff is great, because it can really, patients who traditionally had not had many options, many treatment options left. I think that the advances in interventional radiology really opens up, a whole new category for these patients. And again, when you talk about outcomes, about, extending someone's life and extending someone's healthy life, I think, interventional has really done a great job in treating disease without harming, the good tissue that's around it. And I think that's really what image-guided treatment is based on. It's killing the cancer, but not killing, the normal tissue, or not resecting
Absolutely.
the normal tissue.
And our interventional radiologists are actively involved, just like Dr. Sydow mentioned, in our tumor conferences and our case conferences, and they're working with your oncologist as well to help make decisions on what might be your best treatment option. So they're all in this together to work for you, which is great. It's one of the things I love about working with radiology, because we do get access to all of the specialists, as well as getting to do things to help you guys out there in the community who need information and need help and need treatment. So we're happy to be here for you. One question that came through, another specific Northside question. I know some of you guys may be listening from outside of the Atlanta community, so we won't go into too many details, but the question was, are there the larger bore, the larger donut that Dr. Sydow mentioned, MRIs available, and is there an open MRI available? And the answer is yes. However, as he mentioned, sometimes that's not the best imaging quality for a patient with cancer that needs staging or treatment or diagnosis. So the answer is yes, it's available, but it might not be right for you. And that is something to very specifically discuss with your doctor. And perhaps a doctor will speak to a radiologist about it and they'll make the best decision. Is there anything else you'd like to add to that, Dr. Sydow?
Yeah, just, some protocols simply can't be done on open scanners like a breast MRI. The magnets simply aren't powerful enough to be able to do a breast MRI. So, there are some protocols that just simply shouldn't even be attempted. Yeah.
Right. So that looks like it is, unless there are any more questions that Katie from the cancer support community has for us, I think we've touched on just about everything. Again, there were some more specific breast cancer questions, but I will ask that you join us again in a couple of weeks when we do the breast cancer specific topic. But I will remind you all that we all know it is Breast Cancer Awareness Month, and we are doing lots of mammograms this month, and we do them lots of mammograms at Northside all year long. But if you haven't yet had your mammogram that's due, I encourage all of you guys to do it, and encourage you, if you're a smoker or know a smoker that may benefit from lung cancer screening, there's all sorts of screening programs available with Northside Hospital Imaging, and wherever your community is, I'm sure that there are similar screening options available in your own communities as well. So thank you for joining us. Katie, do you have any more questions for us?
I think that's it. Thank you both for such a great presentation and such a nice conversation during the Q&A. Thank you all the participants for entering such great questions. If you'd like to connect to more virtual oncology support services, please visit Cancer Support Community Atlanta at our website, cscatlanta.org. And you can also find a recording of this presentation next week on our website under our Video Education Library tab. So as we wrap up, I do want to invite Diane, do you have any closing remarks you'd like to share?
Not especially, other than just to say thank you for having us at Northside Radiology Associates. We're super proud to be a part of this cancer support community, and here for you, here for your doctors, here for your family, and thanks for having us.
Thank you. Dr. Sydow, any closing remarks?
No, I want to thank everyone for their attention, and I hope everyone got something out of this that they can use.
Thank you both. We're getting a lot of positive feedback and thanks in the chat box. So thank you everybody for joining us today. And again, check us out, cscatlanta.org. All right, everyone, have a good afternoon.
Thank you, Katie. Thank you, Dr. Sydow.
All right, bye.
Bye.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.